Hello, everyone, and welcome to Brookings. My name is Louise Shaner. I'm the Policy Director of the Hutchins Center on Fiscal Monetary Policy here at Brookings, and along with my colleagues from the USC-Brookings Schaeffer Initiative for Health Policy, I'm so pleased to welcome you today to talk about innovations in prescription drug policy. So it seems like you can't go a day without reading about the problems of affordability with prescription drug prices and about all the various plans to address them, and then how difficult they are to actually get enacted and get through and all the challenges they face. Well, today we're actually going to talk about the experience in Louisiana where they've actually managed to put a plan in place to improve affordability and access to treatment for Hep C. Okay. So I'm really looking forward to this afternoon. I think it's going to be incredibly interesting. Let me just tell you about what we're going to do. So we're going to start the afternoon off with a presentation by Niraj Sood, who's professor of public policy at USC, who's going to provide us with really some basic background on the fundamental idea underlying the Louisiana approach and the Louisiana experiment. And then we will then move on to a discussion with Rebecca Gee, Secretary of the Louisiana Department of Health, who was instrumental in getting this plan actually put into place. And she'll talk about what challenges she faced in trying to do this and what challenges she thinks she faces in the future as well. We'll then bring in some other experts to talk about sort of the broader question about whether or not this model that they've done should be thought of as a model for other states, other drugs, sort of how far can we take this model. And then we're going to end the day with a conversation with Wendell Primus, who is senior policy advisor to Nancy Pelosi, and he's going to talk about the issue of prescription drugs from a federal perspective. I think it's going to be a great afternoon. I thank you all for being here, and we're going to lead it off to Niraj. Thank you.
Louise, thank you for the introduction, and thanks to Brookings for organizing this event. So my journey into Hep C and subscription models started in 2015 when I was invited to be part of a consensus committee for the National Academies of Sciences. And the charge of the committee was to come up with a national strategy to eliminate viral hepatitis, which is both Hep B and Hep C from the US. And so when I was on this committee, like one of the first presentations we had, or one of the first facts we learned, was that every year about 20,000 people in the US die from hepatitis C. And to just give context for this, this is more than the combined death toll of 60 other infectious diseases that are tracked by the CDC. So if you compare this to 9/11, this is 6 times the death toll from 9/11. So this is a stark fact that 20,000 people are dying every year from this disease. And you could still understand this fact, but we also know that there's a cure available for this disease. So that's the second fact that motivated me, which was that in 2014, there was a cure which, if you take a pill for 12 weeks, you no longer have Hep C. The third fact was that the most vulnerable people, so people in Medicaid, only less than 3 in 100 people in Medicaid in a country like the US had access to these cures. If you look at the prison population, the statistics were even more dire. 1 in 100 people in prisons, even though it's a captive audience, it's a population where you treat them, you're going to prevent many more secondary infections. So it makes public health sense to treat this population, yet only 1 in 100 people in prisons with Hep C were being given this cure. So these 3 facts kind of motivated the committee to do something about this problem. So what the committee found was that if we treat 90% of the people who have Hep C with these cures, we can essentially eliminate Hep C as a public health problem. So if we treat 90%, then we no longer have to worry about this problem for generations to come. And the charge for us was, that sounds great, but how are we going to afford this? How are we going to manage to treat 80-90% of the population so that we can eliminate this? Because at current prices, that would have been billions and billions and billions of dollars of spending, which you could see the prisons could not afford, the Medicaid program could not afford, and so on. So the National Academy's report was the first one that actually recommended a subscription model for Hep C. But this model was at the federal level or at the national level. So there were three kind of key points about the model. The first was we wanted to make sure that this was a voluntary transaction between manufacturers of Hep C cures and the federal government, because we were worried about the incentives for innovation. So a simple solution would be to just ignore patents on these drugs, but that would mean we would not get future cures. So we wanted to make sure that we're preserving incentives for innovation, and that's why the voluntary transaction was an important kind of part of this recommendation. The second part was that the way the model works is the federal government gives a lump sum payment to one pharmaceutical firm that is making this cure. And in return for this lump sum payment, the pharmaceutical firm pushes the price of the drug to essentially zero. So basically what we're doing is we're giving you the incentive for innovation upfront, but in return, pharmaceutical firm is guaranteeing access. So price is no longer a barrier for treatment. So that was kind of the basic idea. So since I'm a professor of public policy or economics, I love graphs. So I'm going to show you some graphs to kind of, again, show how the logic of this works. But when we came up with this recommendation, at the same time, Rebecca and Rena, who are going to be panelists, they were on a parallel committee, which was about making medicines affordable. And I remember, they heard about this idea, and they asked me to present the idea to this committee. And I've never seen a government official so excited about economics. So Rebecca was just like, I'm going to do this. This is fantastic. And she had been motivated by the same facts. So she'd been trying to figure this out probably even earlier than I'd been trying to figure this out. And when she saw this, she thought this could kind of break the political impasse, or kind of figure, like, this seemed to be the solution that would make different parties happy and different stakeholders happy. So that's in somewhere where my work stopped, and Rebecca and Rena and the rest of their team's work began, which was to kind of take this idea, convert it into a solution that would actually work in the real world, and especially a solution that would work at the state level and not just at the federal level. So at the same time, about a year later, I published a paper kind of showing the outlines of how this federal solution might work at the state level. And I published a policy brief with the Brookings Institution outlining some of the challenges that might be faced. So now let's kind of go to the idea. So if you think about, economists, again, love demand supply. So this is a demand curve. So this is the price, like on the y-axis, you have the price of the drug, and on the x-axis, you have the patient population that's treated. So if you set a low price, you can treat, sorry, the pointer doesn't work, but you can see if you set a low price, you can treat a lot of patients. So that's shown by the value Q star. So you can treat a lot of patients, but the problem is that the reward for innovation is too low. So the shaded area tells you how much money pharmaceutical firms would make, and that's too low. So if you choose a high price, and remember, it's pharmaceutical firms who are setting the price, so they choose a high price because that leads to higher profits, right? So remember, they're choosing a high price because they want more profits, not because they want to limit access to the drugs. A side effect of high prices is that access to drugs is limited. So at a high price, you move up the demand curve, and instead of treating Q star patients, you're treating a much smaller number of patients. So the basic idea here is, look, let's give these profits up front to the pharmaceutical firm, and in return, let's remove price as a barrier. So in return, let's make the price essentially zero, right? So with this model, you kind of preserve the incentives of innovation. So you're giving profits to pharmaceutical firms up front, but you're also at the same time dramatically improving access because now price is not a barrier. So how would this work So let's take a Hep C example. So suppose there's a state that's treating about 6,000 Medicaid patients, and there are 3 pharmaceutical firms who have a cure for Hep C and who are competing. And let's assume, I don't know what the negotiated price is, so this is just a hypothetical price. Let's assume the price is $40,000. So let's assume firm A or drug A has majority of the market, so they treat about 4,000 patients, and the other 2 firms treat about 1,000 patients. So from a state or federal perspective, so if you're a Medicaid program, the total cost of the program to you is about $240 million under the status quo. So this is what you're spending for treating 6,000 patients. So the way the deal would work is you would go to one of these firms, or you would have competition between these firms, and suppose you negotiate a deal at $200 million. I don't know whether it's going to be 200 million or maybe even lesser than that, but let's assume the deal is at 200 million. And what happens with this deal is once you give a pharmaceutical firm 200 million, let's say we gave it to firm A, the firm that was making 160 million, that firm promises to make the treatment free of cost after they've got their 200 million. So from the firm's perspective, they're winning. Or in the prior market, they were making 160 million, and now they're going to make 200 million. So the firm that actually made the deal is a winner in this market. The state is also a winner because the state was spending 240 million, and instead of that, now they're going to spend 200 million. And patients are also winners because now the drug is free. This price is no longer a barrier to access once you've paid the 200 million. So you've solved the problem for the state, you've solved the problem for patients, and you've solved the problem for the firm that won the deal. The other 2 firms that didn't win the deal are out of the market in this state, and now what are they going to do? They're going to compete, and they're going to make sure they get the deal. So maybe the price is not even 200 million, it could be lesser than that, right? So the key thing, the way this works is because you have competition, that can drive down the price, right? And the second thing is once you've made an upfront payment and the price is 0, price is no longer a barrier to access. So a lot of people have said like, oh, subscription model, volume-based discounts, it's kind of all the same thing. And what I'm trying to show in this chart is that it's not the same thing. So I've kind of put up 3 different models. One is like a pure subscription model from an economics textbook, which is you would pay a fixed upfront fee, and in return for the fee, you get an unlimited supply at 0 cost. Then there's a modified subscription model where you're paying a fixed price for the drug up to a cap. And once the cap is reached, the drug is free. And the third is volume-based discounts, which is if you buy 100 units, you pay price X. If you buy more than 100, the price falls a little bit more. If you buy 1,000, the price falls more, but the price always stays positive. There's some positive number. So only the pure subscription model requires an upfront payment. And only in the pure subscription model, the marginal cost of treating an additional patient is 0. So in the modified subscription model, it's positive up till the time you reach a cap. And after you reach the cap, it is actually 0. For a discounts model, it's never 0. Every additional patient is going to cost the state money, right? So in the modified subscription, only after you've hit the cap, every additional patient is free. And in the pure subscription, once you've made the upfront payment, you have every additional patient is going to be free. So the implication of this is, if you look at this now from the manufacturer's point of view, what's happening is in the pure subscription model, the manufacturer is guaranteed a fixed revenue. That no matter what, after the deal is made, they're going to make a fixed amount of money. So they would prefer a fixed upfront payment rather than some uncertainty about how much money they would make. It depends upon whether the states are going to follow through or not. So given that, they are going to be willing to give higher discounts if you take away the risk for them. So that's why it will be the model which will have the lowest cost for eliminating Hep C. And then you can kind of argue that the modified subscription model would be in the middle and the volume-based discounts would be in the end, right? The other way to think about this is, let's think about the cost to the state with the status quo. So if you've made a deal where you've already given money to the pharmaceutical front up front, the cost is really high of the status quo because you've paid money, and if you don't treat additional people, you've in some sense lost all of that money, right? In the modified subscription model, the cost is somewhere in the middle because you haven't made that upfront payment, so but you still have an incentive to scale up treatment because you want to reach the cap, and then beyond the cap, the treatment is going to be free. And in the volume-based model, there is, in some sense, the cost of the status quo is zero. You don't treat people, you don't pay any additional money. So in some sense, which is the model which has the biggest commitment to elimination, the pure subscription model, and which is the model which can eliminate Hep C at the lowest cost, the pure subscription model. So now let's think about whether this model will work in other markets. So can it work in other states? Yes. But can we replicate Rebecca in other states? I don't know. So it really depends upon, and I think this is important because this is very innovative and you need true leadership to actually implement this. You also need a partnership with CMS. And the third important thing is price is not the only barrier to expanding treatment. So even if you make price zero, you still need to figure out how are you going to test everyone, link them to care, make sure they adhere to therapy, and that's no small task. And finally, this is kind of a minor point, that once you've made the deal, you want to steer demand towards your preferred drug. So now the companies that are not part of the deal, they're going to try every way to make sure that patients are treated with their drug and not the company that made the deal. So you need to kind of manage utilization of the drug towards the preferred drug. Can this work in a non-Medicaid market? It cannot with the current laws, because what will happen is this will change the Medicaid best price. So if United made a deal, what will happen is United will pay upfront to a company, and after that, the price of the drug is going to be zero. And Medicaid best price would say all Medicaid programs should also get the price to be equal to zero. Can this work for other drugs? It can work as long as three conditions hold. The first is that there is an access problem. So we saw for Hep C, there was a big access problem, that even people with insurance could not afford this drug. And there were a lot of people who didn't have access to this drug. The second is the scope for moral hazard is minimal, which basically means if you put the price of this drug at zero, will this encourage inappropriate use? So if you make the price of a Hep C cure zero, people are not just going to take pills because, oh, it's fun to take these pills, right? So you want a treatment where even if the price is zero, only people who need the treatment are getting the treatment. And the third condition is for this deal to be affordable, you want competition between firms. So one example of where all these conditions are kind of met is insulin. It's been in the news, insulin prices are rising. A lot of people cannot afford insulin at these high prices, and there are several firms competing in the market for insulin. So I have just two policy recommendations. One is make it easier for states to implement ideally the pure subscription model. And this might need new regulations because it might need a CMS waiver or new laws. I don't know, I'm not a lawyer, so how that would work. Or maybe just set up, like, provide technical resources to do this. And the second is change Medicaid best price rules to make an exception for subscription models so this can happen in the private side. Thank you.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.